Welcome to the Ckd-Mbd program. We are glad that you have chosen to start the Ckd-Mbd educational program that is offered by the World Kidney Academy. Today, I'm going to talk to you about introduction and history of the Ckd-Mbd. Ckd-Mbd, this term was established in 2006 by the Ckd-Mbd, this organization, which is usually updating the guidelines in nephrology and this different aspects in nephrology. In the past, the terminology of renal osteodystrophy and metabolic renal disease was most commonly used by the nephrologist, but after discovery and establishment of cardiovascular calcification, these terms has been changed, and now this broader term of Ckd-Mbd is used more. So today I'm going to talk to you about the evolution of the Ckd-Mbd, and I'm going to talk to you about the physiology and the pathology, the adaptive and maladaptive, which process is compensatory, which changes is compensatory, and which ones are not compensatory and pathological. Then we'll talk a little bit about the three components of the Ckd-Mbd. First, the abnormalities, the lab abnormalities. Second is the renal osteodystrophy, the bone abnormalities. And the third one will be the cardiovascular calcifications. So in the past, as you see here, the CKD in general, chronic kidney disease is very prevalent among general population. About more than 13% of US population have chronic kidney disease. And chronic kidney disease is usually associated with several metabolic abnormalities that we usually see, especially when the GFR goes down to about 45 or so. So what happened at the beginning, there will be some compensatory changes, some metabolic adaptation that happen. So BTH will go up to try to control and avoid hyperphosphatemia, because BTH is a phosphatory hormone. More recently, we know that FGF23 actually rises very early in this game, and this is also a phosphatoric hormone, so it increases the phosphorus excretion, so it avoids hyperphosphatemia and its devastating consequences. Calcium lately will go down. Vitamin D level early on goes down, especially the active form of vitamin D. All of these lab abnormalities are usually reflecting underlying severe changes at the skeleton level with renal osteodystrophy and bone abnormalities, and at the cardiovascular and endothelial level that's usually associated with increased cardiovascular calcification risk. Consequently, patient will have worse outcome, increased cardiovascular disease, MACE, the major cardiovascular events that can happen and can actually lead to increased mortality. And also at the bone level, this will be associated with increased risk of fracture, pain, decreased mobility, immobilization, and loss of strength. And in children, also it's associated with growth abnormality and skeletal disorder. And of course, this also can increase the chance of death, hospitalization, decreased quality of life, and disability. So Ckd-Mbd is a complex multi-system disorder that includes three components. First is the one that we usually see, and it's very obvious in our patient, which is the laboratory abnormality, with elevated FGF23, elevated BTH, hyperphosphatemia, decreased 125 and also 25 vitamin D level and the disturbed calcium homeostasis. This is usually associated with bone disorder, either with increased bone turnover or decreased bone turnover, mineralization abnormality, loss of bone volume, changes in bone quality and bone quantity, and loss of the skeletal strength. And the third component is the vascular and soft tissue calcification. So now Ckd-Mbd is a multi-system disorder. This is a definition that came in by the KDIGO, the Kidney Disease Improving Global Outcomes. And they said it's a systemic disorder, okay? It's not a local disorder. It's multi-system disease of mineral and bone metabolism due to chronic kidney disease manifested either by one or combination of the following: the lab abnormalities, the bone abnormalities, and the vascular abnormalities. So what happened here, as we know from 2-3 decades at least now, with loss of kidney function, BTH goes up almost more than 80-85% of patients with GFR less than 20 will have hyperparathyroidism. And phosphorus level goes up lately, usually with the GFR, about 40, 45, and goes up lately in the with loss of kidney function in process of the CKD. And calcium, we'll talk about it because hypocalcemia that sometimes we can see in our patient doesn't really reflect the calcium balance, because even if our patient are hypocalcemic, they are on a positive calcium balance. So we just can't say that they have abnormal calcium homeostasis. On the other hand, more, lately after discovery of the FGF23 in 2000, or more than 2 decades ago now, we see that FGF23 is very early biomarker that goes up even with GFR more than 70. And of course, in dialysis patient with, GFR of less than 20, almost 100% of patients will have high FGF23 level, followed by hyperparathyroidism, then followed by hyperphosphatemia. Our dialysis patients usually have about 8-fold increased risk of hip fracture and major stroma fracture and a traumatic fracture. So they can have a fracture even without trauma, or what we call it fragility fracture or low trauma fracture, just with a minor fall in the kitchen or bathroom, or when they slip down, they can fracture one of their major skeleton, especially the hip and the vertebrae. And of course, this rate of fracture, it correlates with the degree of kidney function. So in the past, the first intervention that we have that started in 1970s with early recognition of the hyperphosphatemia, the first but late sign of Ckd-Mbd, we usually try to control this disease by giving aluminum-containing phosphate binders. This is more than 50 years ago. But of course, this aluminum wasn't free of side effects, and we'll talk about it a little bit. Then 1980s, there was introduction of the calcium carbonate, then the calcium acetate in 1990s. But this all calcium-containing phosphate binders was associated with increased risk of cardiovascular calcification. So in 2000, the introduction of non-calcium phosphate lowering agents like sevelamer and lanthanum was a breakthrough in controlling hyperphosphatemia without aggravating the positive calcium balance. The vitamin D analog and vitamin D receptor activator and the active form of vitamin D, as you can see here, was introduced in mid-1990s with the calcitriol, with the alpha calcidol. Then in 2000, there is introduction of baracalcidol and doxycalciferol, the Hectorol and Zimbelar. Then in mid 2000, introduction of calcium sensing receptor agonists that suppress the BTH release. The cinacalcet was a breakthrough. Then in 2010, another breakthrough happened with introduction of the iron-based non-calcium phosphate lowering therapy, like the sacrophilic oxyhydroxide and the ferric citrate. This one called Erexia, this one called Velforo. So this is another interesting and appealing way to control the phosphorus and also to improve the iron deficiency. More lately, there was introduction of two things. First, in the last 5 years, we have been using IV forms of calcium sensing receptor agonist, which is the eticalcitide, or other name, the generic name is Barcipev, which is injection. So it improves the compliance and probably looks like relatively more efficient. However, the GI side effects was almost the same like the cinacalcet, the oral forms of vitamin D receptor agonist. And now there is a tinabinor. So tinabinor is not a phosphate binder, it's a phosphate lowering therapy, and it decreases the phosphate paracellular transfer and movement in the gut. It works through the sodium hydrogen exchanger number 3. So it inhibits, it's given twice a day, and it's not related to meal because it's not a binder. It's just suppress the paracellular transport of phosphorus. The problem with these phosphate binders, they are not free of side effects. Like if we talk about aluminum-based phosphate binders, it can induce aluminum intoxication, and now we're trying to avoid it, especially in the third world countries where we found significant aluminum staining in their bone tissue, and we'll talk about this in the future. But anyway, so aluminum intoxication can cause cognitive dysfunction, can cause osteomalacia and adynamic bone disease, can cause intractable anemia, okay? Then we didn't talk about magnesium-based binder. So there is no FDA-approved magnesium-based binder. However, in practice, we can use magnesium oxide, magnesium hydroxide as a phosphate binder, but it can induce diarrhea. And it can, I mean, if you are using mega doses of this magnesium-based binder, it can also induce hypermagnesemia. Calcium-based binders can cause increased cardiovascular calcification risk and arterial stiffness. Sevelamer and lanthanum can induce a lot of gastrointestinal side effects, especially with constipation, perforation, impaction, and bowel obstruction. Iron-based binders, because it has iron, so also it's sometimes not tolerated by the GI. It can induce nausea, vomiting, it can induce diarrhea and constipation as well. So this is the reason that we are trying to find another safer phosphate binders, or not a phosphate binder, but phosphate lowering therapies like the tinabinor right now. Let's talk a little bit about the parathyroid gland and what happened in our patients with chronic kidney disease. So there is stimulation of calcium sensing receptor because of many reasons, because of relative hypocalcemia, hyperphosphatemia, decrease at 25 and 125 dihydroxy vitamin D level. So there is, there is a suppression of the calcium sensing receptor and a stimulation of the parathyroid gland. So BTH goes up, and the BTH actually induces two things. So far, what we know, one effect is on the kidney and the other in the bone, because there is a BTH1 receptors in kidneys and in bone. There is very little or no BTH receptor in the gut, okay? So it works mainly directly on the kidney and on the bone. In bone, it induces bone resorption. And actually, one of the common mistakes that nephrologists use to understand BTH, because it stimulates bone resorption, it acts on the osteoclasts. But this is wrong. It actually acts on the osteoblast. It doesn't, the osteoclast doesn't have BTH receptors. The BTH receptors are mainly on the osteocytes and osteoblast. So BTH stimulates the osteoblast and osteocyte to secrete rank L, and rank L will stimulate osteoclastogenesis. So the osteoclast has rank L receptors, okay? So, but there is no direct effect of BTH on the osteoclast and on the gut, okay? So what happens is BTH, higher BTH, will try to stimulate the conversion of 25 to 125 vitamin D, which will increase calcium and phosphate absorption in the gut. So indirectly, BTH can affect the gut, but it doesn't have a direct effect. Its effect on the gut through activation of vitamin D, the 125, by activating the 1-alpha hydroxylase enzyme. So BTH, it's we need to understand what is the BTH assay. So because when you send the blood sample to detect the BTH and it gives you a number, it's better to understand what actually you're measuring. Okay, BTH is 184 amino acid. It has two parts. One is the N terminal, which is the biologically active segment, and the other one is the C terminal. C terminal or C fragment doesn't usually have any calcemic biological activity. Most of the biologically active calcemic effect of the BTH resides in the first amino acid, usually 1 to 7, most importantly 1 to 3, okay? The problem is, first of all, we need to understand that our parathyroid gland is very, very important gland. It's endocrine, one of the most important and actively working, day and night, 24/7 glands in our body. We try to estimate how much BTH molecule is secreted in daily basis, and we came in with this complicated equation that actually our body secretes in a daily basis more than quadrillion molecules, about 1.3 quadrillion, not million or billion or trillion, but quadrillion. And this is because the gland is working day and night very hard to control our extracellular calcium level. And actually what we have in our blood is just a small portion, because most of the BTH that is formed inside the gland stays in the gland as pro-BTH, and BTH about 60% stays even if there is low calcium, about 60% goes to the blood and 40% is auto-degraded. If we don't need a lot of calcium, so we don't need a lot of BTH, so in case of the serum calcium level is on the higher level, actually only about 20% of the BTH goes to the circulation, and 80% will be auto-degraded inside the gland. So the gland is forming much, much more of the BTH just in case of emergency, or if we need it, it will be stored in the gland. And here, what happens if we need more BTH? If the serum calcium level goes down, or there is more need to release more BTH to maintain the norm, the extracellular calcium concentration, what happened is by a process called exocytosis, this vesicles inside the gland start to move toward the cell membrane, then rupture, then release in seconds. It's a very quick process to maintain the extracellular calcium concentration. This is called, and this is why not all the BTH formed inside the gland or inside the parathyroid cell goes to the circulation. The majority stay inside the cell. Okay, if we need more and more, then there will be increased BTH synthesis. Not only, these vesicles will be depleted shortly. So now the BTH will increase the synthesis through increased BTH mRNA and gene expression. If we need more and more of the BTH, if there is prolonged need to increase BTH secretion, what happens is then there is a polyclonal proliferation of the parathyroid gland and what we call it parathyroid gland hyperplasia and cellular proliferation. In the CKD process, that here is a normal parathyroid gland in very early CKD, but in moderate CKD, there is glandular hyperplasia, and as we mentioned, it's polyclonal proliferation, increase the number of the cells, increase the size of the gland relatively, with mild decrease of the vitamin D receptor and calcium sensing receptors, okay? Then if we don't control this and the BTH goes higher, from 400, 500 to 800, we see early nodularity. Now there is transformation of this polyclonal glandular hyperplasia to a monoclonal. It's a nodule, it's a small nodule, early nodularity. Still some, of the gland is diffuse hyperplasia with polyclonal, but this start to have early nodularity. Then if we don't control this and BTH goes up, more than 800 or 1,000, then this early nodularity changes and transform to a single big nodule or multinodular parathyroid glandular hyperplasia with severe vitamin D receptor and calcium sensor receptor downregulation. Is this important? Of course, this is important because we try to control hyperpara by working either on the vitamin D receptor or calcium sensing receptor. We give vitamin D analog or we give calcium sensor receptor agonist like the cinacalcet or eticalcetide. If there is severe downregulation, in late cases, actually the medical treatment doesn't work. And at this stage of severe nodular hyperplasia, either with single or multinodular parathyroid gland hyperplasia, we need usually a surgical intervention with parathyroidectomy, and it's a point of no return. Here is a calcium sensing receptor. It's an amazing sensor, and it has, transmembrane domain. It has extracellular domain and transmembrane domain and intercellular domain. It has 7 segments, as we can see here. It senses the serum calcium level. And if the serum calcium level is on the higher side, we don't need BTH secretion. So what happens is it suppresses the BTH gene transcription and release and decrease the vesicle exocytosis because we don't need BTH. But if the calcium goes down, it gets activated, and when it activates the BTH release and secretion and the exocytosis and the BTH gene transcription. Here is a cartoon of whatever happened. This is a short video. Here is the parathyroid gland, 4 glands underneath behind the thyroid gland. And here is a calcium sensing receptor. Here is the extra cellular part of the calcium sensing receptor. And here, how can this receptor regulate the BTH synthesis and secretion? So it's very, very nice illustration. And when the calcium level is low, BTH secretion increase, and it goes to the bone to activate the rank L secretion from osteoblast and start process of osteoclastogenesis and bone resorption. And also it starts to work on the kidney to increase the calcium reabsorption in the proximal and distal convoluted tubules. Okay, so let's go back to the BTH assay. The first BTH assay was discovered early in 1960s, so a long time ago, almost 6 decades ago, by a person who discovered a single polyclonal antibody against the carboxy terminal end of the BTH. Remember, carboxy terminal or the C terminal usually doesn't have the calcemic effect. Most important are these first 6 or 7 amino acid in the N terminal. And again, it's a polyclonal, so it wasn't very specific. But at least it opened the door for the BTH. It was assay and it was very innovative by that time, but it wasn't very sensitive. Over time, in the last 6 decades, we have evolution of the BTH assay from the first one here that was polyclonal in the C terminal to the radioimmune assay when we start using, moving from the terminal part of the C terminal to the mid portion, then to the N terminal, the amino acid terminal, not the C portion. Then in 1990s, we moved from the radioimmune assay to the immunometric assay. And now we are using 2 antibodies, what we call it sandwich ELISA. So we use one called capturing antibody and one called detecting antibody, one to the N terminal, one to the C terminal. And we moved a couple of decades ago to the first amino acids in the N terminal. So this is the 3rd generation, which is more specific compared to the 2nd generation. 2nd generation still is the most widely available, but still it misses the first important amino acid in the N terminal. So what happened is when we send BTH assay, we actually measure the intact BTH. What is the intact? And this is actually misnomer. So intact BTH actually gives you all of these fragments and whole BTH. Here is the whole BTH, the 184, okay? You can detect it by the 3rd generation, not by the 2nd most widely available BTH assay. But in the 2nd generation that we are using, and this is very popular, you can get the whole, you can get the N truncated. Here is N, there is no N terminal, it's only C terminal from 37 to 84. Here is just the first amino acid in the N terminals, which are the most important, are truncated. So this is 784. And you can even get just a small portion of the C terminal, like the 5384. And very rarely you can find only the N terminal without the C terminal. In patients with CKD, they tend to retain the C terminal because it's a bigger molecule. So if you get a BTH value of 1,000 for a patient, this means that maybe the 184, the whole BTH, which is active, biologically active, might be a 500, and the 784, which is lacking the biologically active BTH, might be 50-50, so 500, 500, okay? So here's the biologically active is 500. However, another patient might have the same value, which is 1,000, but it has 80% of the BTH 784, which doesn't have the biological activity or the calcemic effect, and only 200 are biologically active, or vice versa. You can have 800, 80% active, biologically active, and only 20% are biologically inactive. So within a given BTH number, you don't know which one is active, which one is inactive. So this is the misleading part of the BTH assay. Not only that, but you can get the results differently if you are using different assays. So if you are using the disor, it give you very small number. If you are using Siemens Emulite, for example, it gives you 3 to 4 folds higher BTH. Here is an illustration we published several years ago about the first, second, and third generation BTH assay. So the first is polyclonal against the C-terminal. The second is using capturing and detecting antibody, but again, it misses the first amino acids. Then the third is the detecting antibody is just detecting the first 1 to 4 amino acids, which are biologically active. If you are interested, you can read this interesting article, and we summarize the pros and cons of each of the first, second, third generation. First, it's not used anymore because it has poor affinity and specificity, and it's obsolete. Second generation is the most widely used. It's less expensive, and it's adopted by the current practice guideline, either the Ckd-Go or Ckd-Mbd guidelines. But the problem, it cross-reacts with the C-terminal BTH and has wide range of inter-method variability. The third generation, it directly measures the biologically active BTH. It does not cross-react to the C-terminal BTH. It may correlate better with the survival, okay? But it's expensive, it's less widely used, and still not adopted by our guidelines and organization. Then there is another method we can use is to do the 184, which is the whole BTH, over the 784, which is untruncated or, the C-terminal portion. So the biologically active, we call it Kappa ratio, so biologically active over the inactive. This correlate better with bone histomorphometry and give accurate information for the biologically active and inactive. So you have idea about both. Still, it's expensive because you need to do second and third generation BTH assay. So yeah, so I'm just giving you an introduction to understand the complexity of the BTH assay. I don't anticipate you will understand the whole science behind it, but at least you should have some basic information how to interpret and how to recognize the complexity of the BTH assay. Why do we need to treat secondary hyperpara? Because disturbance in calcium, phosphorus, and BTH and vitamin D have been traditionally recognized as one of the risk factor for bone disease and renal osteodystrophy. Not only that, but also it's recognized that abnormal bone homeostasis is associated with increased cardiovascular disease and mortality. So we might be able to reduce the cardiovascular mortality and the fracture risk by improving the Ckd-Mbd parameters. Here in this study, this is a population-based study in CKD patients on dialysis, and they try to find if Ckd-Mbd compared to anemia, compared to inefficient dialysis, has more attributable risk of death. And when they compare these three elements, as you see, if the patient have evidence of Ckd-Mbd with a phosphorus more than 5, calcium more than 10, or BTH more than 600, it puts the patient on a 17.5% attributable risk of death, compared to only 11% for anemia, 5% for inefficient or insufficient dialysis. So the conclusion was, and this was an important population-based study, the conclusion was we should be able to significantly improve mortality of our CKD patient by improving and controlling their Ckd-Mbd parameter. So in patients without chronic kidney disease, they can have calcification, and this calcification usually happen inside the intima because usually there is a plaque, and this plaque rupture because of the atherosclerosis, then there is a calcification in the plaque. But in CKD patients, the calcification process is different because it happens in the medial layer, in the muscle layer, in the smooth muscle cells. And you can see here the coronary arteries has almost the same intensity or more intensity compared to the bone in our CKD patients. So let's talk a little bit about an important concept and discipline, which is bone turnover. Why do we need bone turnover? What is the bone turnover? We need bone turnover basically because our bone is a healthy and a living structure. If it doesn't have bone turnover, this means that it's dead. So to heal up microfracture, to take out old unhealthy bone, and to release calcium and phosphorus when needed from the bone by bone resorption is very essential in our homeostasis. So to have bone formation, this cycle starts by bone resorption. The osteoclast needs to be activated, then start to eat up the bone, erode the bone, and create a cavity. Here's a bone resorption. Here is multinucleated giant cells called osteoclast. It eats up the bone, okay? Then this is the first stage. So you need bone resorption to have bone formation. Here, the osteoclast start to recruit osteoblast to fill in this gap. This is a reversal stage. Then here is the bone formation. So these osteoblasts lay out collagen, then calcium and minerals will come in and will induce the mineralization process. So it fill in the gap. Then the bone will enter in a quiescent or resting stage, and so on. These cycles takes place all the time in our skeleton. What happens in CKD patients, they tend to have either low or high bone turnover. So this physiologic bone turnover is rarely to find in our CKD patient. So when they have little or too little bone turnover, there will be low turnover bone disease or adynamic bone disease, and this will induce premature senility of their bone, unrepaired micro damage, and over-mineralized bone. It's old bone, it's over-mineralized, okay? And on the other hand, if there is high turnover bone disease, there will be loss of bone mass and structure, stress risers, and under-mineralized bone. So it's very hard to see this normal bone formation and bone turnover in CKD patient, but they have either what we call ostitis fibrosa cystica or adynamic bone disease. So bone biopsy is a gold standard in diagnosing renal osteodystrophy. I want you to understand the basic structure of the bone here. Here, this is called osteoid, which is a collagen. It's a matrix. It's a collagen type 1. It's a tough protein. This collagen is unmineralized, the red section here. And this is actually secreted or laid out by the osteoblast. Osteoblasts looks like soldiers. They are lining up on the bone surface and they secrete this osteoid, which is unmineralized bone. Then calcium phosphate and hydroxyapatite comes in and mineralize the bone, and now we'll have this blue bone, which is very, mineralized, okay? But here is a hungry cell, multinucleated giant cells called osteoclast. These osteoclasts, you remember, it start to induce a cavity here, start to eat up this bone and induce a bone resorption to start the process of bone turnover. So this is osteoclast, this is another osteoclast. And here is a bone marrow fibrosis. So this is the reason actually we used to call this is, of course, high turnover bone disease, because you see this, a lot of osteoclasts, a lot of osteoblast, a lot of osteoid, and also a lot of fibrosis. So this is what we used to call osteitis fibrosa cystitis, because it looks like an inflammation, hypercellular, okay? Both osteoclasts and osteoblasts are very prevalent here. Fibrosa because of this bone marrow fibrosis, okay? And cystica because it starts to induce cysts. And actually the bone here would be woven bone because there is high rate of bone formation, so the bone is unstructured or disorganized. On the other hand, you don't see any cells here, and you see the bone volume is very low, and there is no even osteoid like this, because the osteoblasts are very lazy and they are probably not, existing as well. The number of osteoblasts and the function of the osteoblast is very limited, so there is no osteoid. There is decreased bone volume. This is over-mineralized old bone, and there is paucity of cells, and also the bone volume is low. So this is a typical low turnover bone disease. This is another spectrum of the renal osteodystrophy. We call it ROD, or renal osteodystrophy. So you can see the osteoid here is very thick. The osteoid volume is big, and this is an osteomalacia. Osteomalacia because of the osteoblast is forming osteoid, okay? There is no problem with the osteoblast here. The problem here is there is under-mineralized bone, either because of severe vitamin D deficiency, severe hypophosphatemia or hypocalcemia, and ricket patient with hypophosphatemic rickets and hypocalcemia. All of these will lead to unmineralized matrix, unmineralized osteoid, okay? So the bone will be fragile and soft, it's unmineralized. And the fourth spectrum or pattern of renal osteodystrophy is what we call it mixed pattern. In one side, you see the osteoclast and osteitis fibrosa, like this one, and here is the osteoid. On the other side, you see the osteomalacia with increased osteoid volume and osteoid thickness. In the past, we used to, more than 2-3 decades ago, we used to see more high turnover bone disease. But in the last 2 decades, most of the bone histomorphometric study showed that we have more adynamic bone disease than high turnover bone disease, okay? When in this study, very famous study by Barito that was published in Kidney International 2008, there was what we call it the Kidoki guidelines that we maintain the BTH by that time 150 to 300. So if you follow these guidelines, you still have 64%, 2/3 of your patient will have low turnover bone disease. Even BTH more than 300, you still have almost more than 1/3 of patients will have low turnover bone disease. And actually this study and other was the reason that the KDIGO guideline, it changed the BTH target level from 150 to 300. Now we are using 2 to 9 folds of upper limit of normal, which means about 150 to 500 or 600. So the upper limit of 300 was moved up to about 500 or 600 according to your assay to avoid low turnover bone disease. Also in our lab, Malouk and other investigators found that the majority of our bone disease in the last decade or so was low turnover bone disease, especially in white. Maybe in black, it's a mix between high turnover and low turnover bone disease, but in white, the low turnover bone disease is very prevalent. But we are not going to do bone biopsy, which is minimally invasive. We are trying to do more bone biopsies and try to help several programs to initiate bone biopsy programs and the lab. But by the end of the day, we should have a non-invasive tool, especially using a biomarker that can give us an idea about bone turnover. So the importance of these bone turnover markers is it predicts the bone loss and fracture risk and identifies the mechanism behind the bone loss. Because if you do a DEXA scan or if the patient has a traumatic fracture or low trauma fracture, you know that there is a bone loss. But if this bone loss in our CKD patients is related to the low bone formation with low turnover bone disease, or the high bone resorption with high turnover bone disease, or due to something else like the aluminum intoxication, the osteomalacia, or mixed renal dystrophy, you need to do a bone turnover marker. It actually helps to select the treatment, either to give anti-osteoporotic medication to suppress the bone resorption. We call it anti-resorptive therapies like bisphosphonates and denosumab and SERM, the selective estrogen receptor modulator, or if the patient have low turnover bone disease, so the problem is in low bone formation, we need to stimulate bone formation by giving what we call osteoanabolic or bone stimulants, like the BTH, the 134, the teriparatide or abaloparatide, or the monoclonal antibody against sclerostin. It actually also, this use of BTMs, it doesn't only help to choose the right and precise and the proper treatment, but also to monitor the response. Because if you want to repeat the DEXA, you don't repeat the DEXA in 6 months. You need at least a year or 2 to repeat DEXA. But you can use this non-invasive biomarker to monitor the response, to see if the bone formation, the indicator or markers of bone formation is improving or bone resorption is going down, and actually also to monitor offset, of the effect after stopping the medicine. So here, this patient, if you repeat the DEXA scan after 2 years, it's usually too late. But if you redo the bone turnover marker every 3 to 4 months, it will help you to predict what's going on in the bone. It's a complementary to the DEXA scan. It doesn't replace the DEXA or other, bone biopsy if needed, but actually it helps to choose the best treatment and to follow the response to treatment. What are the known bone turnover marker? I don't want to give you, and flood you with, a lot of information, but there is bone formation marker, bone resorption marker. Most widely, we use the bone-specific alkaline phosphatase, or even the total alkaline phosphatase in CKD patients to detect the bone formation rate. And we use the TRAB5B, the tritratate-resistant acid phosphatase, as a bone resorption marker. There is others. There is osteocalcin, there is B1CB, B1NB for bone formation, and there is CTX, NTX, pyridine, and dexopyridine as markers of bone resorption. But in CKD, these biomarkers are retained because they are excreted in the kidney, okay? So they are renally cleared and they are retained in CKD patient, but the bone-specific alkaline phosphatase and tritratate-resistant acid phosphatase are not usually retained. So these, among with the BTH, are the most commonly and most widely used bone turnover marker. If it is hard to do bone-specific, use total alkaline phosphatase, which is available in every place, and actually it helps, very much, except if the patient has liver disease. So most of the alkaline phosphatase comes out from bone, but if the patient have, obstruction in the cholestasis or, liver obstruction or hepatitis or cirrhosis or liver cancer, it actually, the most of the alkaline phosphatase will come up from the liver. So it's important. But if you cannot do, the bone-specific alkaline phosphatase, use the total alkaline phosphatase. See here, the bone-specific alkaline phosphatase gives you very good idea about the bone formation and the bone turnover. The total gives you less, but still you can use it if you cannot do the bone-specific alkaline phosphatase. Here is the specificity and sensitivity. This is an old but important study that examined the effect of using the bone turnover marker, especially with the bone-specific alkaline phosphatase, in conjunction with the PTH to detect the bone turnover. So if you have a PTH of over 200 and bone-specific alkaline phosphatase of over 20, the negative predictive value is very high. It's almost 100 for high turnover bone disease. And on the other hand, if you have PTH less than 200 and bone-specific alkaline phosphatase less than 20, specificity and positive predictive value for low turnover bone disease is very high. So, I mean, if you have PTH less than 200, and the bone-specific alkaline phosphatase less than 20, you don't usually need to do bone biopsies. You can certainly treat this patient for low turnover bone disease. We usually need to do the bone biopsies if these numbers are not very helpful. And if the PTH is between 150 to 300, 400, you don't know what's going on, especially if the bone-specific alkaline phosphatase also is not conclusive. So the diagnostic accuracy of this biomarker has been investigated in several studies. And this is a big study that almost 500 dialysis patients recruited and did bone biopsies. You can see the low turnover bone disease was also prevalent here, more than about 60% of the patient, and a small fraction had normal, and another smaller fraction has high turnover bone disease. The use of BTH along with bone-specific alkaline phosphatase or B1NB are important and augment the positive predictive value and the accuracy and sensitivity and specificity of the bone turnover. But again, I mean, the best value you get if the BTH is more than 9 folds of the upper limit of normal. This is actually gives you certainty about 85, 86% confidence that this patient has high turnover. Still, you can miss about 15% of the time and patient doesn't have high turnover, but at least if you have very high PTH, the positive predictive value and the specificity is very high for high turnover bone disease. On the other hand, if you use the whole PTH, the third generation, it gives you a better specificity. Again, the sensitivity is not great, but the sensitivity is the best if you have the whole PTH less than 2 folds. So this means that, PTH of less than 150 or so, it gives you the best sensitivity. Let's talk a little bit. So we talked about the lab, the abnormalities in our lab with the hyperphosphatemia, hyperpara, and the calcium. Then we talked about the renal osteodystrophy, the second component of the Ckd-Mbd. Let's talk about the last component, which is the cardiovascular calcification, which is usually silent. And what we see is usually undercover a big, unseen portion of the cardiovascular calcifications. The cardiovascular calcification is like a stone. Some people think that giving, magic medicine or even after transplantation, this calcification will go away. No, it doesn't. I mean, you can relatively slow down the progression with the intervention, but actually there is no magic treatment so far that can reverse the cardiovascular calcification. It's very, very devastating and serious disease. And, the magnitude of this calcification or CKD patient is huge. It's about 83% of our dialysis patient has significant cardiovascular calcification, and about more than 50% of patients who just started dialysis and 40% of stage 3 to 4 has significant cardiovascular calcification. Cardiovascular calcification doesn't only induce heart attack, but also induce stroke, can induce arterial stiffness, and systolic hypertension with the systolic number will be low. This is the reason that with loss of elasticity, we will have wide pulse pressure. Actually, it can decrease the fistula survival and increase the failure rate for creating AV fistula. Actually, it can preclude kidney transplantation in extensive cases because you need to do the vascular anastomosis here in the arterial artery. So if there is a lot of calcification, this anastomosis will be very tough. It causes peripheral artery disease, and in severe cases can cause calciphylaxis with skin wound and sloughing, and usually this is very hard to heal and is associated with very high mortality. So it can cause arterial stiffness, can cause stenosis even in the valve and aorta, and in mitral calcification. It can aggravate the systolic hypertension. It affects the myocardium and increase the myocardial fibrosis, can induce conduction defect and arrhythmia, pericarditis. So we usually thought that pericarditis is related to uremia, but it's also related to calcification, and it can induce myocardial dysfunction. Mobility and activity is very important to our CKD patient, but when they don't have enough blood supply to their muscle and the joint, they cannot mobilize, they cannot stay active, they cannot exercise. See this hyperemia that happen when you run, increase the blood flow to the joint, increase the blood flow to bone and to muscle. But in our CKD patient, once they start to mobilize, they'll have stiffness, and because there is no increased blood supply with increased demand of oxygen to the tissue, they will stay less active, and this is actually has very bad consequences. And one of also the earliest sign of this cardiovascular calcification that we don't usually think about is the erectile dysfunction because of the calcification in the dorsal, benile arteries and in the cavernous arteries, both in men and women. Even in women, they don't have menstrual cycles. They are usually amenorrheic if they are on dialysis. And this is not only because of uremia, but also because to have proliferative phase and secretory phase, and the endometrial, you need huge blood supply. And if they have calcification, they usually have, problem with supplying their uterus and endometrium with the blood. And what we usually see, you see the calcification. This is an X-ray, plain X-ray film. You see the calcification is everywhere, in the hand and in the feet. And what you see here, there is no blood supply to the big toe, and also there is no blood supply here to the middle finger. And this is usually associated with this very ugly and very, late and severe poor circulation to the leg and also to the middle finger. We usually thought that this calcification, is usually a passive process. But actually, it's an active process because there is transformation of the osteoblast to start to behave as a vascular smooth muscle cells. Here is this study when they transposed aorta from uremic rats to normal rats, they start to have bone loss. So actually, not only the bone loss is associated with increased cardiovascular calcification, but also increased cardiovascular calcification can lead to bone loss. There is a lot of boromotors that is upregulated in our CKD patients, and there is a lot of cardiovascular calcification inhibitors that goes down in our CKD patient. And what happens is when the phosphate and the calcium goes up, they start to cluster and form calcium phosphate cluster that usually carried by the phytoin, which is a protein. And now they form what we call calciprotein particle 1, which is a primary calciprotein particle, which is amorphous. It still can dissolve in the blood without inducing injury to the tissue. But with excess phosphorus and lack of magnesium, this transforms to CBP2, which is not amorphous, the secondary calciprotein particle, which is crystalline, that start to calcify the soft tissue and the heart and the blood vessel, induce oxidative stress and inflammation, and also induce kidney injury. This is needle-like structure. The calciprotein particle 2 is associated with bad disease. So in patients without chronic kidney disease, when cardiovascular calcification happen, it happen inside the intimal layer that usually compromise patency of the artery, and it's usually eccentric. So the calcification happens on top of atheromatous plaque in cases of atherosclerosis, and the traditional risk factor for atherosclerotic disease. But in CKD patients, it's completely different because the lumen is patent, the calcification happen in the medial layer, in the muscle layer, in the smooth muscle layer that transforms to an osteogenic-like cells with severe stiffness of the artery. So this artery is inelastic, so it cannot dilate whenever it needs more blood supply. It cannot compensate for increased demand of the oxygen and the blood. Here is what happened in patient with end-stage kidney disease. This is just a plain X-ray film. See, it looks like an arteriogram. Here is the calcification without any dye. You see the extensive iliac and pelvic calcification, and here calcification of the arm blood vessels. Here is the severest form of calcification with cannonball metastatic calcification because of severe hyperphosphatemia and calcium overload. This usually is associated with calciphylaxis. You see the subcutaneous calcium deposits that usually sloughs the soft tissue and induce wounds and calciphylaxis. You can get a score of these calciphylaxis. There is a famous Kubila score that's usually 20 out of 24 total score according to the anterior and posterior lumbar calcification, lumbar 1, 2, 3, and 4, and anterior and posterior. So each lumbar vertebrae, there is usually 0, 1, or 2, or 3 calcification score, anterior and posterior. So here is 3, and here is a total is 3, so that's 6 anterior, posterior, time 4, that's out of 24. It can give you a score just by using the plain X-ray film of the lumbar spines. Another famous score for the cardiovascular calcification using X-rays of the hands and the pelvis is the Adragao score. Adragao score, its total score is just 4, and here it can give you the right and the left hand, and the total score in the pelvis is 4 according to the upper right or upper left, lower right and left corners. So out of 4, Adragao score can give you a kind of semi-quantitative assessment of cardiovascular calcification. Also, by using DEXA scan, it can, if you put the patient on lateral position, it can give you a very good idea about anterior and posterior calcification in the aorta. But if you want to be precise and you want to move from semi-quantitative to a quantitative measurement, you can use a multi-slice CT scan of the coronaries and the aorta. It gives you a Gaston score, and severe cases usually are, end-stage kidney disease patient on dialysis for a year or 2. They usually have moderate to severe calcification with a Gaston score of at least 100. Moderate cases 100 to 400, and severe cases usually having more than 400 Agatston scores. Coronary and extracoronary artery calcium score is a predictor of cardiovascular events and mortality in CKD patients. So it's important to measure this calcification score because it gives you an impression about the possibility of having missed the major cardiovascular events and mortality. Other way, other than the radiology, we can also do non-invasive testing, measure the calciprotein particle that we talked about at the beginning. And calciprotein particle in the serum is usually associated with cardiovascular events. So higher calciprotein particle is associated with higher mortality, myocardial infarction, and other cardiovascular events. If you are doing any vascular intervention to your patient, like creating a fistula, or patient having coronary cath or CABG, any vascular procedure, you can ask the surgeon or interventionist to get you a piece of the blood vessel from the vein or the artery. You can see this extensive muscular layer, the medial layer calcification in cases of the chronic kidney disease. So there are several modalities that we can diagnose cardiovascular calcification, but the better is to avoid all these devastating Ckd-Mbd consequences. And there is unacceptable management gap in our Ckd-Mbd management. We need to fill it in. We need to early intervene and avoid the long-term consequences and complication. Using the bone turnover marker and sometimes using bone biopsy helps in precision medicine and to accurately diagnose our cases. Searching for early cardiovascular calcification and trying to use preventive measures when we control the calcium, phosphorus, FGF23, BTH, vitamin D deficiency. All of these abnormalities can retard or delay the progression of Ckd-Mbd. It's better to start early and to try to avoid the later complication, because sometimes it's a point of no return and you cannot reverse it. And this complication is usually associated with very high mortality. I think we'll stop by here, and we need to transform our knowledge to practice. The great aim of education is not the knowledge itself, but the action. So hopefully this little information I gave you today will help you in your practice and to improve your patient's outcome. And thank you so much.